Thank you very much to the moderators and to everyone. Now we'll switch topics entirely. This is my conflicts of interest. In fact, scientific partnerships. I have no direct conflict, even less with this topic. So why ask the question? Because about 3 years ago, at the European level, a group was convened, the heads in charge of guidelines, saying that we have no guidelines regarding hyponatremia. There's strong lobbying regarding Vaptans, and so it may be relevant not to feel pressure from industry and to do something about hyponatremia, not to feel US terrorism in a way. Well, this is not maybe the best term that the speaker chose, she said, to use at the time, but to bring people with different sensitivities together. Here you've got the review where everything was published. There's the intensive care med, a review of endocrinologists, and the nephrologists, because there were endocrinologists, nephrologists, and ICU doctors in this group. This is what you can see here. And it was very interesting because we realized that as ICU doctors, we don't see the same patients at all, and we don't have the same way of doing things. And so we had very fruitful debates. The idea behind these guidelines was to really set hands-on guidelines, and you'll see that this is what we did, and not to really theorize too much. Here, just a teaser with a couple of clinical cases that you should keep in mind, and I'll give you answers at the end. The first clinical, they're not difficult. They're all real-life cases that I saw in my ward. 24-year-old female with delirium, tetany, headaches, and vomiting at the end of a triathlon. She came to the ER. She worsened very quickly with seizures and deep coma. She went to the ICU, then Glasgow at 3, and bilateral mydriasis. On the CT, you can see a major edema, and the transcranial Doppler shows almost signs of a backflow with almost signs of brain death, and you can see initial natremia was 123. And now a 76-year-old female referred to the ER for recent confusional syndrome with disorientation. Very quickly, she deepened with tonic-clonic seizures. This is results: natremia 106, kalemia 2.4, kalemia at 63, glycemia 8.7, and a bit of metabolic alkalosis. And you can see a 71-year-old female referred to the ER for awareness disorders. This is non-specific and very stereotypical. She was disoriented, nausea and vomiting for 48 hours. In her history, she's got pituitary adenoma with prolactin that's under treatment. And when she came to the ER, she had a seizure, generalized seizures, and transferred to the ICU because she still had signs of delirium after seizures. Glasgow score at 6, and also signs of localization. And on the initial blood work, natremia 111, kalemia 3.3, chloremia 75, and glycemia was at 6.7. And I'll draw your attention for once that they've done it. Natriuresis at 120, caluresis at 23, chloruresis at 100. So keep that in mind. And now let's go into the thick of things. What do the guidelines say? How to manage hyponatremia? And not all hyponatremias are alike. The stages are always the same for hyponatremias in the ICU. So mostly severe hyponatremia, and we'll see what severe means here. So several steps. The first step is to determine what hyponatremias have a brain risk, because they are vital. These are the hypotonic hyponatremias, and only those that have a risk of brain edema because of osmotic gradient problems. So we use the viewpoint of even an intern in the ER, eliminate hyponatremias that are not hypotonic, and the major cause for these hyponatremias is hyperglycemia. The second step, once you know that they're hypotonic with a risk of brain edema, you need to identify severe hyponatremias, those for which there's a vital risk and even a secondary risk. And the third step, which is the result of the first two, for the severe and serious ones, you should start treatment urgently, and you also need to identify the source of the hyponatremia at the same time. The first step is to exclude those that do not have a risk of brain risk, non-hypotonic ones. There are several types. First, there are false hyponatremias, which can be hyso or hypertonic, or isotonic or hyperosmolar. Isotonic or hypertonic, the causes of accumulation of sugar, mostly high blood sugar, but you have the same thing when you push mannitol or when you infuse glycine. And then there are things that are not so common. And then there are causes that are hyperosmolar, but which are not isotonic. And when you have isotonic, you have no problems with intracellular hydration, and this is because of alcohols. If you measure plasma osmolarity, you'll have hyperosmolarity, but since alcohol, urea, ethylene glycol go inside the cell directly, there's no osmotic gradient between the two, and so there will be no movement of water. So you'll have plasmatic hyperosmolarity and also inside the cell, but no shift of water, and so no risk of brain edema. So what we said is to calculate plasma osmolality. You can see the formula here, effective osmolality. This is very simple. Formula natremia times 2. You can include kalemia or not. It doesn't really matter. Plus glycemia, either in grams per liter or milligrams per deciliter in millimoles. We have the figures in millimoles. It's much faster. Everything should be in millimoles. And if you can see that in this formula we haven't included urea. It's not an effective osmol, and it's not responsible for water shifting. If you have hypertonia, you can have intracellular dehydration, like here. It's quite the opposite of what you can believe when you have hyponatremia. And if you have hypotony, you can be sure that it's a real hyponatremia, and there's a risk of brain edema. Another thing that can lead to hyponatremia without risk of brain edema, pseudo-hyponatremia, which are isotonic and isoosmolar, which are related to high triglyceride or cholesterol levels in the blood. It's simply a lab artifact. Here you have a kilo of plasma water. There's a solid phase, and there's a phase, an aqueous phase with the solvent with electrolytes in it. In this part, you have 7%, normally 7% in solid phase, so normally 7% proteins and lipids, and 93% water and electrolytes. If you compare that to 1 liter of plasma, you'll have a certain sodium concentration with 7% of the solid phase. And if you have hyperlipidemia or hypertriglyceridemia, hyperproteinemia, that's Kaller-Waldenstrom, not really what we see here in the ICU. If you measure natremia per kilo of plasma water, natremia will be strictly normal. But if you compare that to 1 liter of plasma, since it's 93% water and 7% proteins, you'll see that there's a dilution effect in a way. And this is why, well, they're called pseudo-isonatremia. They're isotonic and isoosmolar. There's no risk of brain natremia. They are not very severe hyponatremia, but hematologists are very familiar with these solutions. So, where is there a risk of brain edema? Well, first you need to exclude hyperglycemia. When you have hyponatremia, it's very easy. You measure glycemia every time you've got hyponatremia, and make sure you look whether you have isotonia or hypotonia. If osmolarity is low, you have hypotonic. Not everyone can have a measure of plasma osmolality immediately. It takes an hour for me, and the lab is not happy because it takes a very long time. And so this is what we do, and I would take it further. You should measure plasmatic tonicity, and if you're in a hospital in France or elsewhere without the facilities, you should accept as hypotonic hyponatremia, a hyponatremia without other causes for hyperosmolarity, what I said, hyperproteinemia or else, or others. So why look whether it's hypotonic? Because of water shifting and the risk of cellular edema, and especially brain edema. Here you can see brain osmoregulation, which is the reason why we distinguished between acute and chronic hydroelectrolytic disorders. Contrary to what you may think, the brain is not a perfect osmometer. Of course, water shifting between the extracellular medium depends on the osmotic gradient, but cells, especially brain cells, can regulate their volume, not entirely, not always, but they can at least cut the losses. Here you have a normal brain with normal volume and normal osmolality. If you have hypotonia, when it kicks in the acute phase, you'll have brain edema because the cells haven't yet had the time to respond, but very quickly in the first few hours there will be a first level of regulation to reduce the osmotic gradient between intra and extracellular media. The only way to do that with hypotonia is to extract active osmoles to the extracellular medium to flatten the gradient. And since it's not a perfect regulation mechanism, it won't set the gradient to zero, it will only reduce it. But in the first couple of days you'll have brain edema, but it will be less than if the brain was a perfect osmometer. And if things continue, things will be even better, and you have a loss of organic osmoles. These are molecules that do take a little time to be synthesized, but it works better as a way to regulate things, because electrolytes are very quickly. You open channels or co-transporters, it's very quick, but this takes some time and it works very well. And so it almost cancels out the osmotic gradient between the extra and the intracellular media. And in chronic cases, the brain, at least in the case of hypotonic hyponatremia, there will be no major edema. And you'll see that it will have an impact on treatment, because if you go too fast in treating the situation, you will reverse the gradient, and this is where there's a major risk. Here you can see what's looming. Continuous central anomalies, but if you are not too quick in responding, well, you can see that risk is dying of brain edema, and this is a therapeutic emergency, and you're not really thinking about demyelination. Very quickly, it depends on how long the disorders has been here for, and in the literature they've always opposed acute and chronic, but not only, there are other issues like sex, hypoxia, and the perioperative phase, and brain edema and demyelination has been described in postoperative in women with hypoxic problems. What I'm saying is old. It's old work by Arief, but it's not. It doesn't date back to the 1600s. Here you can see the impact of sex, of gender. 674 patients with hyponatremia, 54% women, 46% men. And here you can see that it's crystal clear. For once, women have a disadvantage. The risk increases by 28 to have a brain edema in the situation for women. And in our lives, for women, there's not the same risk in the postmenopausal period and the genital activity period. When you're in the genital activity period, there's a higher risk because of hormonal reasons, which explain why channels don't work the same way. I won't go into the details. So things are worse for women. Also, in the case of hypoxia, in patients with hyponatremic encephalopathy, the average level of natremia is low, 112. And here you can see arterial PO2 is at 38, very low, with a lot of brain damage. So a lot of factors which are associated to lead to severe hypotonic hyponatremia, and I like to stick to old work when it's well done. And here, it's relevant to show this chart when talking about hyponatremia. Here, hyponatremia less than 124 and the worsening of neurological disorders, which are increasingly serious. Normal awareness to seizures. If you look at the average or the means, the medians, you can see with the bars, you can see that the lower the natremia, the worse the neurological signs, but not quite, because if you look at things, there are big intervals individually, and here you have a patient seizing with natremia at 118, so nothing to drop dead for, and here a patient at 115 and who's fully aware. And here you can see that the difference between this and that patient is that one was able to adjust, maybe because it's a chronic disorder or other factors, and the other one didn't have time to have brain osmoregulation, and so you won't manage the patients the same way. That's why we issued guidelines based on the neurological severity. So first you need to assess severity, the presence of neurological symptoms and signs of hyponatremic encephalopathy, and whether they're serious or not. If the patient is symptomatic, this means that there's a brain edema, which is a condition for treatment. Here things are very pragmatic. Acute or not, we don't care. Of course, if it's acute, it's more often than not symptomatic, but what matters is the presence of symptoms. And acute or not acute is not easy to know whether the patient has had the disorder for more or less than 48 hours. So to keep it very hands-on, we're saying that you shouldn't think twice about it. Has there been a seizure or not? Do we have natremia levels from 2 days ago or not? Because the patient will be dead by then. And you need to make sure that neurological signs are related to hyponatremia, because they are not specific. You shouldn't miss something unless there are obvious causes. Very often you give them a brain CT because there may be a stroke with bleeding. That's not related to hyponatremia. That's why there are 6 classifications of hyponatremias. First, you need to define severe and moderate, and it's based on neurological and not on natremia levels. So, moderately symptomatic hyponatremia are those for which there's a real figure for hyponatremia with the presence of moderately severe symptoms, and for severely symptomatic, you're looking for severe symptoms. Here on this table you can see the main symptoms of severity. Here moderately severe, nausea without vomiting, confusion, headache, and severe vomiting, cardiorespiratory distress, abnormal and deep somnolence, seizures, and coma with a Glasgow rating under 8. But here we say that this type of symptoms may be related to something else, and so you need to look for other causes to these neurological symptoms before you ascribe them to hyponatremia. And what we're saying is also that this list is not exhaustive, so there may be other symptoms. The second definition that we gave, there was no other way, acute versus chronic. Here you can see that acute, nothing new here. Acute is any hyponatremia that is documented to exist under 48 hours, chronic in excess of 48 hours, and when you don't know, you consider them chronic, unless in the clinical history you can see things that make you think of acute symptoms. In post-operative, it's usually acute because very often patients have had some blood work, and blood work was normal. And here there are also syndromes, polydipsia, potomony, acute absorption. Here you can see intense exercise and so on. Recent thiazides prescription. This is what I see most often in my department, and this is what I highlighted. And now a third definition that doesn't define treatment at all, light versus deep. This is the value of natremia. Light versus deep, mild versus profound. So mild between 130 and 135, moderate 125 to 129, and profound for the natremia value under 125. And for us ICU doctors, these are not the situations we see most often. Then there are small distinctions that I won't have time